We are talking with neurosurgeon Dr. Michael Meriwether. Dr. Meriwether practices in the Tampa Bay area with offices primarily in Sarasota. Dr. Meriwether, we thank you for joining us today.
Thank you, Myron.
You have a tendency to bring to the forefront for our viewers new and innovative techniques in your area of specialty. And today we are pleased to talk about something that you are doing. It may not be new. We don't want people to think it's just the very first thing that's being done, but it's certainly something innovative and is relatively new by surgical standards.
Basically, it's for cervical surgery, for fusion surgery. It's a replacement disc, if you will, but it's actually a fusion device that we call a cage. Cage is sort of an unfortunate word, if you will, but we can talk a bit about that and explain that it's sort of a hollow screw that fits into the place where the disc was and allows healing to take place. On the other hand, you could call it very old because it's basically the same type of surgery that's being done since the mid-1950s by orthopedic surgeons and neurosurgeons in terms of doing cervical disc surgery.
You have been doing for several years another innovative procedure in which you were using an artificial bone substance, a coral, medical grade coral. What is the greater benefit to making the change in now using the cage versus the procedure that you had been doing?
The greater benefit, I think, is that it uses the patient's own bone from that area. From the drilling, there's a small bit of bone that's actually packed into the cage, and then from the placement of the cage. And the cage, if the viewers might imagine, has an external coating that's similar to the type of kitchen device that we use to grate carrots or grate cabbage or whatever you may be grating in the kitchen. And as you do that grating process, the actual grated carrots or whatever go on the inside of the little device that you use in the kitchen. I can't think of the name of it right now, but to make a long story short, that's what happens with the cage as it's screwed in, that the bone from the patient's spine, above and below in that vertebral body, is shaved in small pieces into the center of the cage and then is effectively becomes the fusion graft. So I think it's better in that respect in that it is the patient's own bone, and it's also not taken from another area of the patient as to the traditional type of iliac bone graft would be taken for a cervical fusion procedure. So there are a couple of things to recommend, and I think the third thing is that the stability and weight-bearing characteristics of this titanium implant are certainly, I think, superior to an artificial bone substitute or plating system or whatever in terms of the concept. Plates were a great idea when they first came along, and they still are useful. Even with a cage, sometimes they may be necessary in just the surgeon's judgment. But the plating is another piece of hardware in the neck. It's something else that may break over time or might have to be removed. And so our goal with this procedure would be to have this internal titanium fusion graft, disc replacement, whatever you would like to call it, cage as we call it technically, become incorporated into the spine and as a permanent implant. Now, as far as the patient actually moving their neck from side to side, looking up or down, or driving an automobile or playing sports or whatever they may do, it has very little effect at all. Most of the cervical movement upwards and downwards, looking at the ceiling or looking at the floor, is actually between the base of the skull and the first cervical vertebra. And then the movement from side to side is between the first and the second. So most of these fusion devices are used in the lower cervical spine where most people have degenerative disc problems or traumatic disc injuries, and technically do not cause any loss of motion or movement in the neck.
Let's talk about the candidate for this procedure.
Well, these are people basically that have had neck pain, most of them, and quite frequently with a cervical disc. People will have headaches as well, and the headaches are usually in the back of the neck and head and come around to the temples, and everybody's had a tension headache, I think, at some point in our life, and these are the sort of a tension headache that doesn't go away. Associated with that, and these might be just degenerative process that's taken place in a patient over time and multiple injuries, or it might be a single traumatic event that led to the degeneration of a disc and eventual herniation of the disc. Quite frequently, and the majority of the patients we see will have arm pain. pain into the shoulder blade, and then down into the arm and hand, often to the fingers. They may have numbness and tingling as well, or loss of feeling into the hand and fingers. They may have a loss of reflexes that we test with a little rubber hammer in the office at the biceps reflex or the triceps or other reflexes that we look for. So it is a constellation of symptoms and findings, if you will, both the patient's symptoms and the doctor's findings when they examine them, that would lead us to order an MRI scan, for example, find a problem with a patient's disc that may be herniated or damaging in terms of pressing on a nerve, and then make a plan to pursue that. Initially, all these people go to therapy, and a lot of them get better with therapy. My neck got better with therapy in about 3 weeks. So I think the gold standard is to send people to therapy without progressive neurologic deficit or severe pain that can't be controlled, and see how they do. If they, after that, have problems, don't get better, may get worse at some period, and that may be anywhere from 6 or 8 weeks up to 3 to 6 months, depending upon the patient, their neck, how severe it is, what they do for a living, all that sort of thing. Then they become candidates for evaluation. We talk to them about surgery, show them the options, and let them go home and decide what they want to do.
Dr. Meriwether, I want to thank you once again for sharing this information with us, and we'll look forward to our next encounter.
It's been my pleasure, Myron. Thank you.